Good afternoon and welcome. My name is Heather Kelly, and I am the Program Associate for the Interdisciplinary Nursing Quality Research Initiative. On behalf of everyone at the INQURI program and also on behalf of our colleagues at the Donaghue Foundation, I want to welcome you to the webinar this afternoon, and thank you for joining us. I'd also like to introduce our speaker, Dr. Brian Mittman, who has been involved with the collaboration between INQURI and Donaghue since its inception as a participant in our Funders Forum last year. Dr. is the director of the VA Center for Implementation, Practice, and Research Support and a senior social scientist at the VA UCLA Center for the Study of Healthcare Provider Behavior, both at the U.S. Department of Veterans Affairs and the Greater Los Angeles Healthcare System. He served as a visiting professor in the Department of Health Services, UCLA School of Public Health from 2003 to 2006. Taught at the UCLA Anderson Graduate School of Management from 1986 to 1993. Research interests include implementation science, healthcare quality improvement, and healthcare management. He convened and chaired the planning committee that launched the new journal Implementation Science and serves as co-editor-in-chief of the journal. From 2002 to 2004, he served as interim associate director of the VA's Health Services Research and Development Service, directing the VA Quality Enhancement Research Initiative, or QUERI. I'm going to turn it over to Dr. Mittman, and as I mentioned, I may not have mentioned, we have all of our phones are on mute right now, but we will be opening the phone lines up at the conclusion of the presentation for questions and discussion. So with that, I'm going to turn it over to Dr. Mittman.
Thank you for the introduction, and my thanks to the INQURI program as well as Donaghue and Robert Wood Johnson Foundation for the opportunity to speak in your series. As Heather mentioned in the introduction, I had the opportunity to direct the QUERI program for a few years recently during a period between permanent leadership, and since then have taken every opportunity possible to talk about QUERI and to try to promote interest in QUERI's activities as well as the field of implementation science. So I appreciate this opportunity. The QUERI program is just over 10 years old. It is one of the contributors we feel to quality transformation over the last decade or decade and a half, and has also, we believe, made important contributions to the field of implementation science. And that will be the focus of my remarks today. Keep my talk to roughly 30 to 40 minutes to leave time for open discussion, questions, and answers. Three parts to the talk. I'll begin with a brief overview of VA's quality transformation to tell a story that I hope most of you are familiar with at this point. I'll spend some time talking about the role of QUERI and the role of implementation science in that quality transformation, and then to a brief presentation of some of the key implementation science frameworks that QUERI has developed and that QUERI uses in conducting implementation science and contributing to quality improvement within VA. This provides a brief overview of the VA healthcare delivery system, the Veterans Health Administration. It's the largest integrated healthcare delivery system in the U.S. With a budget of over $25 billion, over 5 million unique patients or users of the VA system. Staff includes approximately 200,000 full-time equivalent employees. This includes over 10,000 physicians, over 50,000 nurses, as well as many ancillary staff and clinicians. The care delivery sites total over 1,300. This includes 150 full-service medical centers, approximately 1,000 freestanding ambulatory care clinics, about 200 counseling centers, 130 nursing homes, and other facilities as well. Because we serve combat veterans, of course, VA patients tend to be older in the U.S. population. They tend to be sicker and poorer as well, and of course, predominantly male. In the 1990s, the Veterans Health Administration launched a major re-engineering reform and a dramatic set of improvements in its quality and safety, improvements in access and value and efficiency. And again, this is a story that I'm sure most of you have heard told before. During this period, or since the early 1990s, we've seen a doubling of the VA patient population with approximately a stable budget. This has been changing in recent years with a new influx of veterans. But during this period, we saw dramatic decreases in staffing and cost per patients. And at this point, VA is widely recognized as having leading quality, safety, technology, care management and so on, that's industry leading within the U.S. as well as internationally. So VA's reputation and the quality of care have gone from essentially being towards the bottom of everyone's list to being at the very top, and this is recognized both within the industry as well as outside. A number of articles have been published in leading journals that document not only the effects or the outcome of the transformation, but also the processes and the mechanisms. A number of these have appeared in New England Journal of Medicine. This is one example that contains many of the details of the transformation. There have been a number of articles published in Annals of Internal Medicine as well that document and demonstrate the VA quality relative to other systems, healthcare quality. This article on the screen is actually interesting because it uses the same data and methods that were employed in Beth McGlynn's New England Journal of Medicine article, showing that on average patients in the U.S. receive just over half of the recommended care that evidence-based recommendations suggest. The numbers for VA at this time were roughly two-thirds. So again, documentation of the higher level of quality within VA than across the country nationally. And a number of studies that have examined quality of care in specific clinical conditions, in this case diabetes. So again, these are just a few of the many examples of articles that do provide deep documentation of the transformation, the quality improvement and reform. The question, of course, is what are some of the key factors that underlie this transformation that have led to the transformation? This slide lists just a few of them. Many observers would trace the original impetus to what we like to refer to as VA's near-death experience during the Clinton health reform discussions. One of the proposals that was on the table involved essentially shutting down the VA system and providing veterans with a voucher to seek care in the private sector. Among reasons for this was the fact, as I said, that at the time VA's quality and efficiency were near the bottom rather than at the top. So this led to considerable interest in major reform and to the recruitment of visionary and committed leadership that essentially designed and led the reform over the ensuing years. The existence of taxpayer support was another important factor. They succeeded in making large investments in information technology, for example, that according to an article in Health Affairs recently have in fact paid off in a significant manner. But there are other investments as well that were made possible by taxpayer support, and the fact that they did not need to worry about profits and ensuring that external stakeholders, other than, of course, Congress and the public, were satisfied with the investments. So again, these were perhaps considered to be risky investments, but each of them have paid off. Generally speaking, the stakeholders that VA has to address and whose concerns are important have been trusting and supportive of the reform. The reform itself and the strategy that was designed by the new leadership was highly coordinated and comprehensive. And perhaps more importantly, from the perspective of the QUERI program and those of us in research, one of the features of the transformation was very active engagement of health service researchers, engaged in ways that ranged from developing and compiling evidence to support the transformation, supporting measurement and monitoring activities, and providing technical assistance in many different ways. Let me turn to a series of slides talking about the specific role of QUERI and the role of implementation science in this transformation. The QUERI program has been in existence for roughly 10 years, since the late 1990s. The QUERI mission is summarized on this slide: to enhance the quality, outcomes, and efficiency of VA healthcare by systematically implementing evidence-based clinical practice guidelines and innovations into routine clinical practice. At this point, there are 9 QUERI coordinating centers scattered across the country, located at the larger VAs in the 9 clinical conditions that are listed on this slide. Most of these are the conditions that tend to attract the greatest attention outside VA as well in terms of quality improvement, given their large incidence, prevalence, as well as the costs and the burden of these diseases. 2 of them, of course, are specific areas of interest for VA, and those with polytrauma bladder-related injuries as well as spinal cord injury. There are no features of QUERI and the infrastructure within the VA healthcare delivery system that are important in understanding QUERI's contribution. As I indicated, VA consists of the 9 disease-specific centers. I describe them on this slide as virtual because although the centers do have a VA where the leadership of the center are located, the researchers themselves are scattered across the country located at different VAs. So the coordinating centers essentially try to coordinate research conducted by researchers located throughout the U.S. QUERI has a set of dedicated funding and review mechanisms that are separate from the other research funding and review mechanisms within VA. VA, of course, itself is a large integrated delivery system that represents a laboratory for the QUERI research program. VA had benefit of national clinical policies and extensive IT infrastructure, performance measurement and incentive programs, and many other elements that are in place that support quality improvement and can be integrated into the quality improvement strategies or programs that the QUERI investigators develop and evaluate. We also, of course, have a very conducive leadership orientation and culture, which is heavily oriented towards research and towards quality improvement. And one of the important characteristics, though, of QUERI and its relationship to the rest of VA is the fact that there is extensive overlap between QUERI leadership and researchers and the leadership of the VA healthcare delivery systems itself. At the program level, many of the steering committee members for the QUERI program are VA leaders. Each of the QUERI centers has leadership and a steering committee that, again, consist of many of the key VA leaders. In any of the QUERI centers, for example, diabetes, the clinical coordinator, who essentially serves as the associate director of the QUERI Center, is also the national clinical policy lead for diabetes in VA. And an example of a tightly integrated and overlapping leadership and membership of these different kinds of activities. But the broader question, and that is, how has QUERI contributed to the VA quality reform? There are a couple of different categories that are useful to consider. First of all, there are a number of indirect contributions that QUERI has made over the last 10 years. QUERI researchers are active members of the VA Department of Defense Clinical Practice Guideline Council and Performance Measures Work Group, so they contribute their research and evidence-based expertise to those activities. There are a number of major efforts within VA to address specific clinical programs and problems. In the case of coronary syndrome, a report conducted by VA that identified some quality problems with ACS care within VA. QUERI played a major role in addressing the problems identified by that report and in designing and putting in place new programs and new clinical policies to improve care. And as indicated, there's a fair amount of overlap between QUERI and the clinical program staff within VA. But there have been a number of significant direct contributions that QUERI has made to quality improvement, and these include specific implementation studies that have evaluated and identified quality gaps within VA, have developed specific quality improvement programs and interventions, and have implemented and evaluated those, and again contributed to improved quality. I've listed a couple of examples on the slide, including one in spinal cord injury, as well as a large program of research in depression care management in primary care, TIDES, WAVES, RETIDES, a number of individual projects with water-related acronyms that have comprised that research program. And these are specific implementation studies that have made direct contributions to quality improvement within VA. So building on that idea, the specific implementation studies that QUERI has conducted, I'd like to walk through a few slides talking a bit about how VA and QUERI views implementation research, and then transition to a set of slides that will present our frameworks. This is the definition of implementation research that we published in the opening editorial for the journal Implementation Science. It's based on previously published definitions and is essentially the definition used within VA. I'll read that and then read the definition and highlight two key features. The definition states implementation research is the scientific study of methods to promote the systematic uptake of research findings and other evidence-based practices into routine practice, and hence to improve the quality and effectiveness of health services. It includes the study of influences on healthcare professional and organizational behavior. those of you who see the slides will see that I've highlighted two phrases in yellow that essentially capture two distinct types of implementation research. The first is essentially interventional research. Implementation research develops and evaluates specific interventions or programs to implement evidence-based practice and change practice patterns. The second highlighted phrase captures more of an observational type of research, and that is studies that examine influences on healthcare professional and organizational behavior. I'll talk a bit more about each of these types over the next few slides. In QUERI, we view two separate, distinct, but clearly overlapping policy and practice problems as the foundations or the motivations for implementation research. The first is a set of issues that are widely recognized and discussed within NIH, within the Institute of Medicine and elsewhere, and have been discussed in a number of large commission reports, including a set of reports from the IOM Clinical Research Roundtable, essentially identifying two translational roadblocks or two areas in which the progression of ideas from basic science into clinical research, first of all, and from clinical research into practice, where that progression has been slowed. NIH Roadmap Initiative and a number of other NIH funding initiatives are basically targeting these translational roadblocks, and they are often described as T1 and T2, or translation type 1, translation type 2. That is one of the areas of policy and practice discussion and issues that drive implementation research within QUERI. The other, of course, is the quality chasm, gaps in the quality, safety, equity, efficiency, timeliness, patient-centeredness of healthcare. And generally speaking, when we interact with colleagues at ARC and Academy Health and others who are health services researchers, we talk about the quality chasm and quality gaps and quality improvement research. When we interact with folks at NIH and colleagues elsewhere who take a bit more of a research orientation, we talk about translational roadblocks and the need to overcome the second translational roadblock. But fundamentally, both of these are aspects of implementation science. They both involve the same types of theories and research methods and so on. And even though they are discussed in two separate ways, it's actually a larger category of policy and practice concerns and foundations that is one and the same. So in these policy and practice foundations, the field of implementation research has a couple of closely related policy and practice goals. And again, this is the way that we think about implementation research within the VA. First of all, the field aims to produce reliable strategies for improving health-related processes and outcomes and to facilitate widespread adoption of these strategies. The field also aims to improve health-related processes and outcomes within the participating sites and settings. And this is one of the unique features of implementation research, the fact that sites that participate do feel a need to see improvement. This complicates studies when we'd like to have control sites, of course. These are important practice goals to keep in mind in designing and conducting implementation research. If we this more from the science perspective, of course, the goals of implementation research are those that are shared by other fields of research. The field aims to generate new insights and generalizable knowledge regarding dissemination and implementation processes, barriers, facilities, and strategies. And again, as with other fields of science, the field aims to develop, test, and refine specific theories, hypotheses, models, and principles. So the policy practice goals on the previous slide, as well as the research goals on this slide, these are all goals that drive and guide the conduct of implementation research within VA. Now, I think the research itself, there's a series of challenges that QUERI has discovered, and others as well, but that QUERI has confronted over its 10 years or so of activity. And these are the challenges that underlie the frameworks that I'll be presenting in the next several slides. First of all, in terms of the quality of the research that we conduct, the value, the ability of that research to generate useful insights and findings, there are questions and challenges related to the planning of implementation studies. What is the optimal timing of those studies relative to the research that produced the evidence-based practices that we wish to implement? What is the appropriate sequencing of implementation and related studies? What kind of research approaches are appropriate? What sorts of designs and methods should we be using? and we be reporting implementation studies. There are a number of active debates underway in some of these areas. For example, in the area of research approaches, there's an active debate underway in the published literature as well as in the hallways, at least, of some implementation research centers that debates the value and relative contributions and the need for more or less of two different types of research, with one group arguing that the field of implementation science has not made as much progress as it could because there are too few large randomized controlled trials that have been designed and conducted, and therefore the findings of most of the work that use what they believe to be softer methods are not valid and are not useful. The argument states that, in fact, the large RCTs that have been designed and conducted that tend to rely too heavily on black box approaches do not generate useful insights, that the level of heterogeneity and the level of complexity and variability in the settings that we study and in the interventions or QI programs or implementation programs that we develop, that each of these is too large. The heterogeneity and the variability are too large to allow to use large RCT methods, and instead what we need is greater use of qualitative methods and others. So this is one example of the type of challenge that we face in the field and the kinds of issues that researchers are struggling with in order to determine what types of research to conduct and when and how in order to generate better insights and to lead to better quality and safety improvement. In terms of quantity, I believe all of you who are actively involved in the field recognize that the field needs more researchers, more projects. We need more funding opportunities, more training, and the need for implementation research is far greater than the supply at this point. The third set of slides, and my final slides in the talk, I'd like to present a few frameworks that QUERI has developed and is using to, again, structure the planning and the conduct and reporting of our research. There are 4 frameworks that we use. I will actually briefly present on just the first 3 today. Those of you who are interested in the 4th, if you would contact me separately, I can send you some materials. Frameworks relate to the challenges that I described in my previous slide. First of all, issues related to the optimal sequence and timing of implementation studies and related kinds of studies, and I'll describe 3 frameworks that help in this regard. The 4th framework that I will not present, though, is one that serves as a template to guide the design and conduct and reporting of implementation studies that addresses issues such as what are the appropriate research approaches, which kinds of study designs and methods should be included, and so on. So it goes back to the first of the policy and practice foundations for implementation research that I briefly mentioned, and that is the issue of translational roadblocks. This highly simplified depiction of the translational roadblock story based on work of the IOM Clinical Research Roundtable and others, and merely points out the fact that in an ideal, efficiently operating research system, we would see rapid progression of ideas from basic and lab research, and where those ideas have potential value and applicability for clinical research, they would be quickly picked up by the clinical research community, and we would see the development of effective clinical treatments. Second phase, of course, is that we would see those clinical treatments, once developed and tested and proven to be effective, rapidly taken up by the healthcare delivery system, which would lead to improved health. And that idea flow is depicted by the black arrows. What we see instead, though, is too much flow along the yellow arrows, where findings from basic and lab research are essentially published and sit on the shelf for far too long, and findings from clinical research are published and again sit on the shelf for too long and are immediately taken up by the healthcare delivery system and therefore do not lead to improved health. So this pipeline is the foundation for some of the QUERI frameworks. The version that has been developed and guides our research identifies many of the subphases within the overall set of phases of research depicted by the simple pipeline. And if I get your attention to the center of this diagram, the small yellow pipe that's labeled clinical research, this is the part of the process in which the evidence-based practices or effective practices are generated. it's not just the field of clinical research, of course, that generates effective practices, but also the fields of health behavior research and even health services research. Generates effective care models, methods for improving access, generates new screening tools and other kinds of techniques. All of these types of research represent pre-implementation research. It's the body of work that generates the effective practices that we as implementation researchers hope to implement or facilitate implementation. That work, of course, that is generally efficacy-oriented research is followed by effectiveness studies that demonstrate the effectiveness of these clinical innovations and treatments and tools in real-world settings. And it's actually the effectiveness studies that would then be followed by implementation research. So the point of this framework is to help researchers think a bit about when implementation research is appropriate, that they do in fact need to wait until effectiveness studies have been completed, not try to implement studies or innovations or treatments that have been an efficacy phase of research and other aspects of timing. So this is one of the frameworks that QUERI uses in order to develop plans for the appropriate timing of implementation studies. The second work that I'd like to present is what we sometimes refer to as the QUERI 10 Commandments. This is the QUERI process that was developed at the outset of the QUERI program. It consists of a series of specific steps, the most important of which are steps 3 and then 4, 5, and 6. 3 essentially is a set of activities to identify quality gaps or implementation gaps, identify areas where best practices and treatments are not being followed and where implementation research is needed. 4, 5, and 6 then involve the actual implementation research itself, studies that implement programs or implementation strategies to promote best practices, and then in step 5 and 6, research activities that evaluate the effectiveness of those implementation programs. After about 5 years of QUERI research following the simple 6-step process, as we continued to think about the kinds of studies and research activities that were necessary, actually realized that those skipped some of the important activities and often weren't sufficient in order to generate reliable and effective approaches for improving quality and implementing evidence-based practice. So the result of that experience was to develop an expanded version of the framework. And what is important here, of course, is not the specific steps in the labels, but instead the kinds of research that are covered by those labels. So for step 3, in order to provide an adequate foundation for the actual quality improvement intervention development, it's not enough to simply identify quality gaps or implementation gaps and then proceed to try to close those gaps. Queries 3B, 3C, and 3D are additional research activities that the researchers have identified that are needed in order to provide adequate evidence base and adequate guidance for those who wish to improve quality. So in the case of query step 3C, the idea here is to actually diagnose the causes of the quality gaps. It's not enough merely to know that quality is inadequate. We need to understand something about the barriers and the causes. In step 3, again, focus on identifying the barriers and the facilitators. And there are sub-steps that have been developed for query steps 4, 5, and 6, and I won't take the time to go through these now, but would be happy to discuss them later. We also, through the course of our query research, identified categories of activity, again, that were not covered by the basic query 6-step process, but need to be included in an implementation research portfolio in order to generate the kinds of insights and findings needed to be effective in improving quality. These include, for example, step O, a set of observational studies that would attempt to understand and identify the determinants of implementation and implementation success in an observational mode rather than in an experimental mode. This is an expanded version of one of the pipeline diagrams that attempts to place each of the individual steps within the pipeline. And in the interest interest of time, I won't go through this in detail, but those of you who are interested in understanding the specific activities and how they relate to one another and the sequence of individual studies that comprise an overall integrated implementation research program, this pipeline should be helpful. The third framework, the last framework that I will present today, is depicted in the lower right-hand corner of this study, this pipeline rather. And this depicts 3 or 4 different types of studies that comprise implementation research in the QUERI step 4, 5, 6 phase, and that is the individual studies that develop and evaluate implementation programs. The phase model that's depicted here is driven by the FDA 4-phase model for drug trials. During the 1970s and well into the 80s and even the 90s, much of the implementation research that was conducted consisted of moderately sized implementation trials or experimental studies evaluating the effectiveness of different quality improvement or implementation strategies. And VA conducted a number of these as well. Finding within VA, within the QUERI program, but also outside, was that most of those programs that were evaluated in these large trials tended not to be effective. In many cases, the ineffectiveness was due to relatively simple findings and features of the implementation strategies or quality improvement strategies that probably could have been fixed relatively easily. But in a rigorous trial, where essentially the rules of the game do not allow you to make changes to the implementation strategy, that was not possible. So that sort of experience and other thinking and reading led to the development of this 4-phase framework. Actually lists the 4 phases in more detail. And again, as I said, guided by the FDA 4-phase model for conducting clinical studies, the framework encourages researchers to begin with a small pilot study and to proceed for the pilot into larger risk trials of implementation strategies only after completing the pilot work and additional developmental work. And ideally, we would move from our pilot studies and our large trials into a phase 4 monitoring phase, in which actually within VA at least would hand over responsibility for the quality improvement program to one of the VA operations units, and the researchers would step back and take on more of a monitoring role and would provide feedback to the VA leadership group that was responsible for ongoing use of that quality improvement program. It's a way of building a quality improvement strategy, beginning with some pilot work and working all the way through national implementation in a way that allows for ongoing refinement and doesn't commit us to any specific strategy too early and to invent in a large quality improvement program before we've completed the research process. So I conclude at this point with the last framework. This slide lists a small number of websites that are available for more information. The third of these URLs actually is the homepage for a series of articles in the journal Implementation Science that presents the QUERI frameworks that I've described, as well as many of the studies that have used those frameworks. There are QUERI-related studies that have been published as well. I have we're developing an annotated bibliography of these studies, but those of you who are interested in more information and more examples of QUERI studies, please contact me and I'd be happy to send along a list. So at this point I will stop and open up for questions.
Wonderful, thank you. I'm going to take the phones off of mute so that you can, there's already been submitted. Commitment. Excellent explanation of the very complex world of implementation research. To what degree does the national network aspect of QUERI contribute to the rigor of the science? Which of the QUERI pipeline principles can or should be extrapolated to other improvement research networks?
Well, as I indicated in the beginning, does have certain advantages, and this is a question that arises from time to time, and one that we, QUERI and VA researchers, are very interested in as we consider approaching NIH and ARC for funding as well. where the knee-jerk reaction is always, well, the VA is different. You're a large integrated healthcare delivery system. Moreover, you are a military system, and therefore new clinical policies can be developed at central office and essentially imposed on the rest of the system. None of that is true, of course. There are practice-based research networks that replicate some of the features of QUERI. There are, of course, other integrated delivery systems within VA, such as Kaiser. But I think that the base idea is that the blind principles, as well as the idea that we would see handovers from researcher practice leaders in terms of implementation programs and strategies, that we would begin with the pilot studies and work up, but also we would sequence our studies in a way that does not launch into implementation research and interventional research before we've completed some of the diagnostic work and before we've completed the efficacy and effectiveness studies. I guess in my view, all of that applies to the non-VA setting as well, and that for those interested in conducting this work on a large scale, that the practice-based research network infrastructure be viewed as the best example or version of an integrated delivery system that should allow for much of this work to be done in the same manner as within VA.
I've had a question come in about the slides, and I posted it, but just wanted to reiterate that the slides and this presentation will be made available on the INQRI website later this afternoon. So if you do want to download the slides, or if you wanted to take a look back at the presentation at a later date, it'll be available for viewing on your desktop. Questions?
Hi, Heather.
Yes.
Yeah, this is Kendall Gallagher. I have a question. The question relates to, is on the step O, about the observational studies of implementation processes. I'm curious as far as what Dr. Mittman and the other research scientists have seen as far as barriers and facilitators as it relates to the implementation processes. Is it something that they're seeing that is specific, or are they seeing a general pattern of barriers and facilitators across studies?
I think actually it's a bit early. There are general patterns. There are some researchers that are attempting to identify them. I think the general idea of using what we label Step O, or observational methods, to try to study those barriers and facilitators is one that the field is increasingly recognizing as important. There's obviously a trade-off between internal validity and external validity. When we run the large randomized controlled trials of implementation strategies, typically those are strategies that we as researchers have developed, oftentimes in collaboration with our practice leaders, but within VA and outside as well. We're essentially, in a somewhat artificial manner, coming into a system and telling the practice leaders as well as the clinicians, these are priorities for improvement, these are implementation strategies and quality improvement programs that we believe you should be using, and we will assign half of you to the intervention condition and half to the control condition. You will see what happens. Barriers and facilitators that are observed in response to that sort of experiment may not completely resemble those that would be observed when the VA, as a healthcare delivery system, implements its own programs for improvement and does so in a more natural way. So despite the tendency for at least some researchers to prefer experimental approaches over observational and natural experiments and studying natural history, so to speak, my view is that we can learn a lot more about barriers and facilitators by observing and by studying and documenting the kinds of change processes and improvement efforts that are underway naturally. One of the efforts within the field, and there are some VA colleagues who are involved in this, is an effort to identify the broad categories of factors that include characteristics of the settings and the practice organizations, also specific categories of barriers and facilitators, and to develop lists essentially of variables that all researchers ideally would measure. And the patterns that you talk about, where we'd like to see if there are certain barriers that tend to be seen in most circumstances, until we begin a more focused effort on data collection that would be consistent across different studies, and it would allow us to begin to accumulate findings, the degree of certainty in our conclusions, and the extent to which we can make definitive statements that certain barriers do tend to dominate others. We're just not there yet within the field, but that is one of the goals that is clearly towards the top of the list, and something that all researchers in the field recognize as being important.
Thank you.
And then I have a couple that have come in. The first is just informational for everyone. The new Improvement Research Network, which is NIH-funded, is patterned after PBRNs and offers opportunity to collaboratively conduct improvement research in multiple sites. You can access the network via the website www.isrn.net, which is in the chat feature right now. It looks like it would be a great resource. Also, we have two questions that have come in. The first is from Lynn Gardner at Donaghue. The results of the McGlynn article showing about 2/3 of VA clinical practice based on empirical guidelines is really impressive. Can you mention again when this was done and what has been the overall response to this?
Sure. So, the specific article is the second of the three that I had essentially flashed on the screen. It was an article led by Steve Ash, who worked with Beth McGlynn on her study. The original study, of course, was published in New England Journal of Medicine in 2003, showing that just barely over half of all recommended care was received by the patients in their large sample. A couple of years later, a study was published in Annals of Internal Medicine, and again, the second that I had shown, demonstrating that the equivalent figures in VA were roughly 2/3 rather than 50%. And the reaction was, this is just one of many articles that have demonstrated that, VA quality transformation essentially has been effective, that VA is now delivering care, that at least according to the kinds of quality measures that we have available, is better than that of non-VA systems, and VA is now participating in some of the other national quality monitoring and reporting programs that are in place within the U.S.
A comment in from Richard Malarkey at Kaiser Permanente related to the first question. QUERI works well in the VA, but in other integrated networks, or especially in traditional care delivery settings, concern can be summed up as all implementation is local. Example, implementation work, research may best work like IHI collaboratives.
Sure, I think that's a good point. And again, despite the fact that VA is a national system and it does have a military tradition, there's saying within VA, which is if you've seen one VA, you've seen one VA. That VA facilities are also all very different. We do have certain advantages. So, for example, within the IHI Breakthrough Series collaborative approach, where each of the teams does work on its own local quality problems in a way that basically the team itself is responsible for data collection and analysis and development of specific improvement strategies and so on. VA has conducted a large number of similar collaboratives. Our local teams are responsible for local improvement, and yet they do have the ability to rely on central resources for some of the data collection and some of the data analysis. So I think the application of the IHI Breakthrough Series model within a large system like VA is somewhat different. It does involve some adaptations and some efficiencies. But I think the key point of the question, which is, does this have to be localized? I think the answer is yes. This is another challenge for us as researchers, where we do need to account and allow for local adaptation in a way that sometimes results in the specific quality improvement intervention or implementation intervention varying a bit across the different sites. And it complicates the analysis, and it complicates our ability to definitively say the sites that use the intervention succeeded in improving quality, while those that did not succeed in improving quality, because in fact the intervention varies. But I guess this relates to the internal validity versus external validity trade-off. It does seem better to maximize external validity where possible and make sure that the improvement strategies that are employed and evaluated are optimized to meet the needs of the local settings. But I think to answer the overall question, I think the QUERI approach does allow for that. And again, the QUERI approach recognizes that if you've seen one VA, you've seen one VA, and therefore I do believe that it applies to even more heterogeneous settings as well, such as the mixed collection of facilities and delivery systems that might participate in a practice-based research network or another large study that involves different types of settings.
Thank you. Do we have any other questions, either on the phone or in the chat?
Nope.
Well, Dr. Min, thank you so much for such a wonderful presentation. I think it's really been useful to everyone. And later I'll be getting the slides and the itself up on the INQRI website. If anybody does have a question that occurs to them after we get off the phone, I always make this offer. You can always reach out to me. I will get your questions submitted to Dr. Mittman, and I'm going to throw my email address up in the chat window now. So if you do have any questions, please feel free to reach out. In time, though, thank you so much for joining us, and I appreciate all of you taking the time today. Thank you so much.
Thank you.